Now, in an unprecedented break from tradition, I'm pleased to announce that the slides that I mailed in and that all of you have access to, and I've signed the release so you can get to them later if you haven't looked at them already, are the same slides that I'm actually going to project, which for me is a first. And the reason that is because of the assignment that I was given, which focused on recent changes in treatment guidelines. I found that as much as I wanted to on the plane, I could not actually change the guidelines on my way over to the meeting. So that's why I couldn't change any of the slides. So let's move ahead. In terms of disclosure, somehow this did not make it into your handout, even though we sent it in a while back. But my wife is a consultant for DAVA, and I have done consulting work and legal work for other companies listed. Genentech Roche in particular applies to this topic. The outline for my talk is as follows. I'd like to review with you 4 key points. The first regarding neoadjuvant use of the second-generation HER2 dimerization inhibitor antibody pertuzumab. I'd like to show you data on adjuvant weekly paclitaxel and trastuzumab for early-stage lymph node negative HER2-positive breast cancer. I'd like to show you data from the metastatic first-line CLEOPATRA trial, which was the pivotal registrational trial of pertuzumab. And then finally, I'd like to review data from you on TDM1 and ask you to consider really hearsay from a press release regarding first-line data. Then I'll show you some pivotal second-line data which has won regulatory approval, and I'll show you new data in the salvage setting, which guidelines have already addressed. Now, if you consider pertuzumab, the second-generation HER2 antibody therapeutic, it's unique that in contrast to trastuzumab, which is illustrated here in its murine form, these are the mouse antibodies, 45 and 2C4, from which trastuzumab and pertuzumab were derived initially. You can see the binding site here on the extracellular domain of HER2 is distinct between these 2 different antibodies. In particular, 2C4 blocks this subdomain 2, which is the dimerization interface for HER2. So HER2 cannot dimerize with any other HER receptor, even after ligand activation, in the presence of pertuzumab. So that's a unique feature that trastuzumab does not have. Moreover, since there are 2 different epitopes for these 2 distinct antibodies, you could consider giving them both at the same time, because it is, at least in theory, possible that both could bind to the same HER2 target simultaneously. And that might afford interesting biology as well. So I'll show you the data and the impact in the clinic simply from these nuances of structure-function relationships of 2 different HER2-directed antibodies. And it's really quite striking that such a nuance can actually result in clinical impact that have survival consequences indeed. So I'd like to begin in the neoadjuvant setting. As per the outline, this is the NeoSphere trial, which I'm sure you're familiar with by now, published data by Luca Gianni and his group. This is a randomized trial, about 100 patients per arm, randomizing HER2-positive early-stage disease patients into treatment with docetaxel trastuzumab, the same chemo trastuzumab with the addition of pertuzumab, an interesting arm with just the 2 antibodies alone with no chemo, and then finally a control of docetaxel and pertuzumab with no trastuzumab. Post-op, all of these patients went on to get standard adjuvant anthracycline-based chemotherapy and a year of trastuzumab total. So there's no concern in terms of their ultimate exposure to a full course of chemo and a year of trastuzumab in each of the arms. Now, the primary endpoint to this trial was pathologic complete response rate, and I'll show you the top-line data directly. On the far left is the control arm, docetaxel trastuzumab. The orange bar is the pathologic complete response rate of 45.8% in those subjects that were randomized to receive pertuzumab in addition to trastuzumab chemo. Interestingly, the 2 antibodies had some activity. 17% is a respectable path-CR for an all-biological approach. Unfortunately, we're not smart enough yet to be able to identify biomarkers that can cull out those patients in particular from an intent to treat population otherwise. And then finally note that docetaxel pertuzumab was fairly respectable in terms of having not dissimilar pathologic complete response to docetaxel trastuzumab. Indeed, those differences were not statistically significant from the trastuzumab chemo control. But the marked increase in pathologic complete response rate in the pertuzumab randomized subjects was felt to be provocative and sparked a lot of interest. And indeed, there are follow-up trials, which I'll show you next. And this data set ultimately did lead to a change in guidelines, which I'll show you as well. Now, in terms of these pertuzumab-based neoadjuvant regimens, additional safety data has been acquired, including both anthracycline-based combinations and non-anthracycline, about 70+ patients per arm in the so-called Trifina study. And again, we're looking at pathologic complete response rates. Shown are two different definitions for pathologic complete response rate. One allows residual DCIS, which are in these higher bars, and the other definition is with no residual DCIS at all, which are the lower bars, but similar path CRs by either definition. And I would argue, even though this is randomized phase 2 data with a small n, very respectable path CR rates, approaching 50%, even 60% with these regimens. The key endpoint of the study, however, was actually safety, specifically cardiac safety. And you can see that the percentage of patients who had declines in the LVF by more than 10% and below 50 was around 5% or a little less in all three arms, indicating that these regimens are arguably safe, at least from a cardiac safety point of view, and could be considered, therefore, for neoadjuvant application if approved. Now, this is the cardiac safety from the NeoSphere study that I've already shown you. And I use this because it actually shows all of the patients at all of the time points. There was just one subject here that had a precipitous decline, and interestingly, that was in the 2 antibody alone arm. But you can see that these other regimens also are consistent with the Trifina data in that these pertuzumab-based regimens don't seem to have any added cardiotoxicity that can be measured. So reassuring data from a safety point of view. Now, it turns out the enthusiasm for pertuzumab in the early stage setting that was sparked by these neoadjuvant trials has now graduated onto large prospective randomized phase 3 adjuvant pertuzumab trials. And this is the ongoing Affinity trial, which randomizes 3,800 plus subjects to chemotrastuzumab placebo or chemotrastuzumab pertuzumab. So you can see this is a CLEOPATRA-like experimental arm and a standard chemotrastuzumab control arm in this study. And this study is ongoing. It is yet to report, but it clearly demonstrated commitment on the part of the sponsor to evaluate pertuzumab in the early stage HER2-positive setting in a critical way with very large numbers and robust statistical power. Interestingly, the chemo options for this trial included both anthracycline as well as non-anthracycline-based regimens at the discretion of the investigator. Now, it turns out that around the time that the NeoSphere trial was completed and that additional safety data was being gathered and the adjuvant trial was being ramped up, the FDA came out with a new guidance for consideration of an accelerated pathway to approval for neoadjuvant therapeutics in early stage breast cancer. And this was happening at the regulatory authority more or less independent from what was going on in industry with this particular sets of data, these particular sets of data. So interestingly enough, the stars kind of all aligned in as much as the FDA guidance stated that if you have robust pathologic complete response rate data that are compelling and statistically significant, if you have follow-on safety data that don't suggest any particular safety signals of concern, and if you demonstrate a commitment to large registrational phase 3 neoadjuvant or adjuvant trials to make sure that the time to event data line up with the path-CR data at the end of the day, they would consider accelerated approval on the basis of those three criteria. And pertuzumab was the first compound after that guidance was issued, in my estimation, that actually fulfilled all those criteria, and therefore, not surprisingly perhaps, the FDA gave an approval, an accelerated approval indeed, for pertuzumab. This is the first drug approved for preoperative breast cancer treatment ever, and certainly the first for HER2-positive disease. And it's on the basis of this progressive stance that the regulatory agency has taken to try to bring important therapeutic advances to our patients earlier in real time. Obviously, if the phase 3 trial fails to confirm the neoadjuvant path-CR intermediate endpoint data, then this accelerated approval would be withdrawn. And I think that's perfectly okay. I'm willing to take that chance as a practicing clinician because if certain drugs hold great promise, I would rather have the option to allow patients to consider those sooner than later, particularly if they have robust efficacy signals in the advanced disease setting as well. So this has made it now into the NCCN manual. Shown are the on-label NCCN updates, that is, the 3 regimens that are in the package insert that are FDA approved. Perhaps more in terms of controversy, there was a lot of controversy that was generated around a footnote that was made in the NCCN guidelines. And the footnote is at the bottom of the page, and bottom of the slide rather, and it indicates the reality that should a patient see a surgeon first with a T2N1 lesion, let's say, and have lumpectomy and sentinel lymph node biopsy, et cetera, prior to seeing the medical oncologist, there's really no difference in the biology of that patient's breast cancer compared to a similar patient that saw a medical oncologist first and was considered for a neoadjuvant pertuzumab regimen. Consequently, the NCCN committee felt compelled to acknowledge that fact that the impact on biology of micrometastatic disease in those 2 scenarios would be the same whether you got preoperative or postoperative pertuzumab. So they put a footnote in the compendium listing suggesting that you could consider adjuvant pertuzumab for somebody that has already been resected for HER2-positive early stage disease. Now this is very, very progressive, I must say, and controversial to say the least. And I wouldn't say that the payers necessarily buy into this reflexly. I've had to do peer-to-peer consultations, usually successfully, but I would say that at least in my jurisdiction, that would not be guaranteed. So use this information judiciously and make sure you have pre-authorization before recommending this in the adjuvant setting. They did not specify, you can see in their language, what the duration of the adjuvant pertuzumab would be, but I certainly would not push a payer to go beyond the 4 to 6 cycles that are approved under the FDA accelerated approval basis. At least that's been my habit thus far, until we get the data from the Affinity trial. And then finally, the NCCN rightly pointed out that there's really no difference in terms of cardiac safety signals between FEC 100 or FEC 120 based combination regimens versus doxorubicin cyclophosphamide combinations. And also there would be no expectation for difference in either efficacy or safety, in particular for the 2 taxanes. So they suggest that paclitaxel could be substituted for docetaxel and that would be a reasonable proposition in the NCCN guidelines, and I agree with that. Moving on now to smaller stage 1 HER2-positive disease. There has been a trial conducted by the CLGB called the APT trial. These data were really striking. This is a approximately 400 patient non-randomized trial that looked at these patients. You can see the breakdown of their stage. About half the patients had lesions that were less than a centimeter, while the other half were between 1 and 3 centimeters. So about a 50-50 split there. Most were T1B and T1C, but almost 20% were T1As, indeed. But at any rate, in this non-randomized trial of merely weekly paclitaxel times 12, and then 1 year of standard adjuvant trastuzumab every 3 weeks, you can see the projected 3-year disease-free survival rate is 98.7%. So when I brought these data back to the Stanford campus, the first person I showed this to was Saul Rosenberg, and I told him we finally had a breast cancer data set that can rival a Hodgkin's disease data set, and he agreed. So striking data. On the basis of this finding, this regimen, the weekly paclitaxel and trastuzumab for 1 year, is now in the NCCN guidelines for your consideration for stage 1 HER2-positive disease. Now, I mentioned earlier that there is a robust efficacy signal in the metastatic disease setting for pertuzumab. And this data set has just recently been updated just a few weeks ago in mid-February in the New England Journal. This is the long-term survival analysis of the pivotal CLEOPATRA trial, which was the registrational pertuzumab first-line HER2-positive metastatic study. And as you recall, this is about an 800-patient study, first-line HER2-positive disease, randomized to docetaxel trastuzumab and a placebo, or docetaxel trastuzumab and pertuzumab. And what we see now is that the overall survival signal is really profound. A nearly 16-month difference at the median in HER2-positive disease, and in the experimental arm containing pertuzumab, now the longest reported median overall survival in the literature for HER2-positive first-line metastatic breast cancer, 56.5 months. So stunning data indeed, and it's all back to this understanding the structure-function relationship of the binding sites of 2 different antibodies on the HER2 extracellular domain, and this is the clinical impact that was gleaned as a result of those fundamental biological observations. So striking data, and I'm sure this weighed in the FDA's decision regarding the accelerated approval in the neoadjuvant setting as well. Now, there is some toxicity in the aggregate data by the addition of pertuzumab. In particular, generally low-grade diarrhea is increased. You'll notice the grade 3 and 4, though, is not dissimilar between the placebo arm and the pertuzumab arm. There's also some increase in rash in the pertuzumab randomized subjects. There's more mucositis, generally low grade in this pertuzumab randomized group, and more febrile neutropenia as well. So compared to placebo, in the aggregate data, there is some increase in toxicity by adding pertuzumab. However, I must tell you that the investigators who participated in this trial, when patients were randomized to placebo versus pertuzumab, as an individual patient, it was impossible for the investigators or their staff to tell the difference about randomization amongst an individual subject. It's only the aggregate data where some of these observations were gleaned. But I think most of these can be mitigated simply by dose modification of docetaxel. These are largely docetaxel-associated adverse events, and that's certainly what we do at our center to get around any of these adverse events with the CLEOPATRA-like regimens. The other option, of course, is to substitute taxanes and simply use weekly paclitaxel instead of docetaxel. And that also gets around a lot of these docetaxel-associated toxicities, particularly the GI toxicity and the myelosuppression. Now, all the regimens I've shown you so far, unfortunately, are still chemo-based. And our goal in developing HER2 antibodies back in the early 90s, our initial naive goal was to see whether they could substitute for cytotoxics. Sadly, that goal was not achieved. But now we have a new technology, the technology of antibody-drug conjugates. And this could solve the dilemma of delivering chemotherapy and a HER2 antibody simultaneously, and yet mitigating against the toxicity of the chemotherapy component. And it had been suggested that it might be possible to do this by employing an antibody-drug conjugate construct to deliver a cytotoxic chemo-like payload using the trastuzumab merely as a delivery vehicle to track the cytotoxic to the tumor site. So at the time that TDM1 was being developed, it was thought that it's important to fine-tune the linker chemistry because you wanted a linker that's stable enough to survive in the circulation and not cause toxicity by the free drug in the circulation. But you don't want it too stable that the cytotoxic won't be liberated once the drug reaches the tumor site. So in a series of experiments looking at linker chemistry in-licensed from Imedex, They had linkers that were least stable up to more stable. And as a negative control for these experiments, they made a linker with no disulfide that is a completely stable linker that will never release the DM1. It turns out in all of their experiments trying to fine-tune this linker chemistry, this negative control proved to be the best. So how can you explain how this could possibly have activity when the linker cannot release the DM1? Literally, it can't. So they had to go back to the lab and do some cell biology experiments to find out what's going on. And it turns out, to make a very long story short, that what was happening is that when HER2 and HER2 antibodies bind one another, a fraction of the HER2 receptors undergo a process called receptor-mediated endocytosis, and that brings the complex inside the cell. From this vantage point, they can either be recirculated back up to the cell surface in a recycling mechanism, or they can be targeted for degradation in the lysosome. And it turns out the fraction of these complexes containing TDM1 that are targeted for degradation in the lysosome can release the TDM1 still stuck to the linker, because it's not a cleavable linker, still stuck to the lysine amino acid from the trastuzumab antibody backbone. So this mechanism involves complete degradation of the trastuzumab, which then releases the TDM1 still stuck to the linker, which is still active against its microtubule target. So the primary DM1 cytotoxic catabolite of this mechanism is lysine from the trastuzumab, linker called MCC, and DM1. Just fascinating, unexpected science, but again, with clinical implications. I'd like to summarize the TDM1 clinical data with you by going backwards from late-stage salvage setting, then to second line, and then some consideration and discussion of TDM1 in the first line. So in this sort of last-line salvage trial called Teresa, investigators were allowed to randomize 600-plus patients in a 2-to-1 fashion to either TDM1 at the standard approved dose, 3.6 mg per kg every 3 weeks, or a treatment of physician's choice, which was essentially HER2-targeted therapy and or chemo du jour at the physician's discretion. So a very interesting study design. We've seen some of these in the breast cancer literature, so a very effective study design in some cases. And that's the design that was chosen to study TDM1 in this context. Now, if you look at these patients, about half are ER positive, as you would expect from any HER2 positive cohort, but look at the visceral involvement. About 3/4 had visceral involvement. Metastatic disease, about 95%, as opposed to locally recurrent, local regional unresectable disease. And then look at the number of prior regimens for advanced disease. Only about 1/3 of these patients had 3 or fewer prior regimens in the advanced disease setting. About 1/3 had 4 or 5 prior lines of therapy in the advanced disease setting. And about 30% almost had greater than 5 prior lines of therapy. So this is a heavily pretreated group, a group with a 10% incidence of brain metastasis indeed at baseline. So not a group where you would expect to see necessarily strong efficacy signals because of the emergence of drug resistance with all the previous lines of therapy. So this was an ambitious cohort to study. In terms of the control group, the treatment of physician's choice, TPC, these are the regimens. You can see they were largely chemo-trastuzumab based, about 68.5%. Another 10% had lapatinib and trastuzumab, and smaller fractions had other. So predominantly trastuzumab containing, about 80% had trastuzumab in the control arm. So a fair comparator arm. This is the top line primary endpoint graphical analysis on the left and summary on the right. The short summary is that there was a significant improvement in PFS favoring the TDM1 arm compared to TPC. There was a numerical improvement in overall survival at the time of this interim analysis. However, it did not cross the efficacy stopping boundary statistically, so that needs more time to mature. There was an improvement in overall response rate in the TDM1 randomized patients, and there were fewer grade 3 adverse events because TDM1 does not have the chemo-like toxicities of the treatment of physician's choice options, which had quite a few patients had chemo, and the rest had lapatinib-based regimens. Now, moving into second line, this is the Amelia pivotal trial in over 900 patients with prior taxane and trastuzumab, who were randomized at the time to the then-approved FDA regimen of capecitabine and lapatinib in the second-line setting versus TDM1. I'm showing you the New England Journal paper with PFS on the left and overall survival mature data on the right, and both were significantly improved by the randomization to TDM1 compared to capecitabine and lapatinib. So this has been FDA approved for a while already, and certainly is already in the guidelines for your consideration, and is a very popular second-line regimen at this point. In terms of toxicities of TDM1, please be mindful of transaminase elevation as well as thrombocytopenia, and then more rarely be advised that there is a rare syndrome called nodular regenerative hyperplasia, which has a clinical presentation of portal hypertension, usually without transaminase elevation, and the recommendation if you encounter that toxicity is to stop the drug. There was no increase in toxicity compared to the control arm in the TDM1 randomized patients compared to a lapatinib chemo base, but clearly fewer chemo-like side effects with TDM1 compared to the fluoropyrimidine-based control. So, in the NCCN guidelines, preferred agents for trastuzumab exposed HER2-positive advanced disease patients, TDM1, adotrastuzumab emtansine, is in the guidelines for your consideration. Finally, what about the first line for TDM1? There has been a first-line metastatic breast cancer randomized phase 2 trial, small study, only 137 patients, randomized 1-to-1 to TDM1 and standard dose and schedule versus docetaxel trastuzumab. And interestingly, when these data were first presented, it was quite provocative because there was actually a benefit in terms of PFS to the patients randomized to TDM1 compared to control. Not unexpectedly, fewer patients discontinued treatment due to adverse events in the TDM arm as well because of the known toxicities of docetaxel in the control arm. So this begged the question, could we do a follow-on phase 3 study of TDM1 in the first-line setting to try to confirm these results to see maybe TDM1 might be even better than chemotrastuzumab in first-line treated patients. So this has been attempted in the so-called MARIANNE trial, over 1,000 HER2-positive patients, first-line metastatic setting, randomized to the control arm at the time these studies were started, which was taxane trastuzumab, versus TDM1 and placebo at the bottom, versus a provocative experimental arm of TDM1 and pertuzumab. Now, if you think about that experimental arm at its root, it's chemo, which is DM1, trastuzumab, T, and pertuzumab. Well, that's a CLEOPATRA-like combination. So based on the CLEOPATRA trial results, there was high enthusiasm that this arm might be able to beat all of the others if it follows suit according to the observations in the CLEOPATRA trial, if you buy this notion that TDM1 is kind of like chemo and trastuzumab, they just happen to be covalently linked. Well, in a press release in December, we have learned that this trial met its non-inferiority endpoint. However, neither TDM1-containing treatment arm significantly improved PFS compared to trastuzumab chemo. And that's kind of a surprise because the expectation was for this to be the winner, but this is why we do randomized controlled phase 3 studies. It's very important to follow on and not rely on one's preconceived notions. Adverse events in the two experimental arms were consistent with the known toxicities of both DM1 and pertuzumab. So these data have not yet been presented, and we anxiously await presentation of this to find out the details. Now, in terms of trying to understand the differences between the CLEOPATRA trial in the first line, where pertuzumab seemed to add benefit, versus the MARIANNE trial, the patient populations were somewhat different. The MARIANNE trial allowed patients on with short disease-free intervals. There was less de novo metastatic breast cancer in that trial. Most of these patients had prior adjuvant therapy. Therefore, more patients had prior taxanes, and more patients had prior trastuzumab exposure compared to the CLEOPATRA trial. Maybe these differences in demographics explains the failure of the pertuzumab arm in the MARIANNE trial. I don't know, but this is for your consideration as an armchair explanation for the negative results, sadly. Now, in terms of the guidelines, This kind of leaves CLEOPATRA firmly entrenched as the preferred first-line regimen. So I suspect in the wake of the MARIANNE trial, this recommendation will likely not change. It'll be interesting to see whether the NCCN takes a liking to the non-inferiority endpoint of the TDM1 arms in the MARIANNE study, and TDM1 could very well be added as a consideration in the first line in future guidelines on the basis of the non-inferiority endpoint. That remains to be seen, but will be considered, no doubt. In conclusion, in preparation for this talk, for one time it finally gave me an opportunity to actually read some of the guidelines, because I don't spend my time doing that unless I'm doing peer-to-peer phone calls with insurance company people. And what I found is that these ASCO guidelines were the most concise, the most direct, and the most complete, the easiest to read, and more like the Apple interface compared to the PC Windows interface or DOS or something of the NCCN. And what I liked about it is that it's short and sweet. It says that first line, CLEOPATRA carries the day. For selected ER-positive patients, you could still consider endocrine therapy with or without HER2-targeted therapy. We don't have time to get into that, but there are randomized trials that suggest that endocrine therapy plus HER2-targeted therapy may be a consideration in that setting. Second line, TDM1 is an obvious solution, although there's no data on TDM1 after CLEOPATRA progressors. I'll grant you that. And then finally, third line is other HER2-targeted combinations, moving on to the HER2 kinase inhibitor-based combinations based on lapatinib in particular, and then finally chemo du jour and trastuzumab. With that, I'd like to thank and acknowledge the investigators and patients and their families who participated in many of these studies that I've shown you. And this slide I chose deliberately because it just has a lot of investigators from a lot of these slides, for a lot of these trials, and it's the most I could fit onto one slide. A lot of hard work went into these data sets, and fortunately it has led to very real clinical impact, including survival benefits for many of these HER2 targeting approaches. Thank you for your attention.